Firstly, my name's Hilary Grocon. I'm an anesthesiologist at the University of Manitoba in Winnipeg. I'm also the editor-in-chief of the Canadian Journal of Anesthesia, and it's a great pleasure to serve as the moderator in this debate on anticoagulation. I know that this debate is the only thing holding you from your lunch, so we're going to move right on. And you note that this is not the first of the debates in this particular conference. A couple other things to note. I'm not Donald Rettelmeier, who is an amazingly difficult act to follow after that great debate yesterday. I'll also tell you that for those that watch or listen to the debaters on CBC Radio, I'm not Steve Patterson, okay? This is also not the CBC, but I will tell you it's the Perioperative Care Congress. It's the PCC, not the CBC. But before I introduce our two debaters, I'm going to sort of mix this debate up a little bit, and I will tell you that this upcoming hard-fought battle is not just for sort of academic gesticulation and pure adulation. There are some real prizes for our award winners today. So before I introduce them, I want to tell you what the prizes are. Okay, so I know this is Toronto, and hockey is a distant, if not disappointing, memory for all of you. But Canada's team, yes, the Winnipeg Jets from my town are still going strong. Thank you. So accordingly, I have some gifts for the winner and the loser of this upcoming debate. So the winner will receive this specially made, one-of-a-kind Jets lanyard acquired at huge expense, I'll tell you. It was 999 cents that I got from the magazine and chewing gum vendor near Gate 11 at the Winnipeg Airport, okay? So the winner will be able to proudly wear this. The loser, on the other hand, can drown their sorrows in this similarly unique, one-of-a-kind Winnipeg Jets shot glass. So that's what we have.
Looks perfect for schnapps, David.
Okay.
Yeah,
So
but they're going to win anyway.
So let's get started with our debater introductions. Now I will tell you, I was given some bios of these fine doctors some time ago, but I decided to do my own research to supplement it. So firstly, this debater is a native of Fredericton and a graduate of Queen's University with cardiology training, yes, at the University of Manitoba in Winnipeg. Go Jets. He's now enrolled in the clinical investigator program at McMaster and has published over 40 peer-reviewed articles, including the most recent Gloria AF registry addressing stroke prevention and atrial fibrillation that was published just 2 months ago. Let's hope he brings his own glory to this debate. Please meet Bill McIntyre. Now, on the other hand, this debater is a trained internist and cardiologist originally from Basel, Switzerland, and now an associate professor at McMaster, widely published in clinical trials, particularly addressing the field of atrial fibrillation and its complications. What you don't know is his oratorical skills include fluency in German, English, and French. And interestingly, if you look up on PubMed, his most cited publication is a JAMA article from 2008 addressing the role of alcohol consumption on atrial fibrillation in women. He tells me that he has studied drunk women in all 3 languages. Please welcome Dr. David Conen.
That's why I'm going for this one.
So let's start a debate. Whereas many say atrial fibrillation, warfarin, NOACs, who needs them? Be it resolved that patients with new post-operative atrial fibrillation should receive therapeutic-dose anticoagulation for 6 to 12 months. Let's let the debate begin with David, who will address the issue of should we just say no to anticoagulation? David.
Yes, we should just say no. But let me get something straight first. Usually this is the time when you say, thank you for the invitation to present here and for the opportunity to talk. I'm not going to say that here. Look at this matchup. Is this a fair matchup? On one hand, you have a young, brilliant, very fluent English-speaking guy from Canada. On the other hand, you have a European, less well-looking, less young, less intelligent, who first heard about debaters last week. Bill probably got some debaters in his breast milk. So, I mean, PJ, is this the best thing you can come up with? Whoever in this audience have heard of a funny Swiss guy? You see, nobody. We can talk about cheese, chocolate. I mean, we can talk about your watches that you probably don't wear, but not about fun, please. So, and the only thing I learned about debates during that Congress is usually PJ comes up, debates against somebody, and then wins at the end for somewhat obscure reason. So PJ, would you please come up and do your job? No, he doesn't want. Okay, so let's talk about perioperative atrial fibrillation. As you heard before, perioperative AFib is bad. It leads to hemodynamic changes, prolonged hospital stays. So patients are not happy, cardiologists are not happy, surgeons are not happy because they have to delay or postpone surgeries because of there is no beds. But is this preventable through anticoagulation? No, it's not. The only thing you prevent with anticoagulation is strokes. And as you heard, there is probably a slightly increased risk of stroke among patients with perioperative atrial fibrillation, but the absolute risk of stroke is unknown so far. So should we subject patients with perioperative atrial fibrillation to the risks of anticoagulations? This is not sugar pills, so I think it's not clear, so we should not do it, and should probably do a trial altogether, Swiss and Canadian, but we should certainly not put people on anticoagulation in the perioperative setting, because you might know, I don't have any slides because there's no data to show that perioperative atrial fibrillation should be anticoagulated, that it prevents stroke. So there's no data, so I say clearly no. Thank you.
Okay, thank you, David. Now let's see if Bill can convince us of the opposite. And rather than just saying no, should we say NOAC to anticoagulation? Can he cardiovert our opinion? Bill.
So, David, you might not have a lot of experience debating, but I think the organizers have thrown you a bone here. As a Swiss national, you're used to opting out or staying neutral, and they did give you the con. So, we know that it's common to have AFib after non-cardiac surgery. The incidence is actually anywhere from 1 to 35%. Trust me, I've read all of the literature. So for the patients in this situation, there's two things that are different than they were before they went into post-operative AF. One, they've had surgery, and two, they are sitting in a hospital where somebody is taking their vitals, and they're probably on some sort of an ECG monitoring. So yeah, it's possible that post-operative atrial fibrillation is directly and uniquely because of a reversible precipitant, and thus it's unlikely to recur after the precipitant is removed, thus not having any impact on the long-term prognosis. On the other hand, post-operative AFib might just be the first detection of a chronic condition that is already present but not diagnosed. You've probably heard of it. It's called atrial fibrillation. So if the latter case were true, post-operative AFib is just AFib, there would be three things that would probably hold up. One, do these people have AFib detected again in the future? The answer is yes. Depending on how long you project out and where you study, anywhere from half to 2/3 of these people are going to have garden variety atrial fibrillation again. Number two, are they at long-term risk of stroke? Yes. In large observational studies using California registry data, people with a presumed temporary cause of atrial fibrillation, including the periop, have higher risk of stroke than people who underwent an operation but didn't have AFib, and in other studies, a similar risk of stroke to people who just have atrial fibrillation. And the third question, are there signals that they benefit from oral anticoagulation? Yes, again, patients with a presumed temporary cause seem to show about a halving of their risk in observational studies. Yes, it's not RCT data, but it's the same trend that we see in the other studies. No reason to believe that what we're looking at is any different.
Bill, thank you very much, and we've got ourselves a debate. Okay, so the next part of this debate is the bare knuckle round. Contestants, 60 seconds each, put your best foot forward, up the dose of humor, prevent any stasis in this audience. David.
I can't do that, sorry. No, but as Bill said, if you project long enough, people will get atrial fibrillation. Yes, if you look at healthy 45-year-old men and women, the lifetime risk of atrial fibrillation is 40%. So if your perspective is lifetime, then yes, I agree with you, but maybe not in the shorter term. Let me tell you a story. Who knows about Greek mythology? Some, okay. So then you certainly have heard about Daedalus and Icarus, who were incarcerated in Crete in a prison, and they wanted to flee over the ocean because they felt lonely in the prison. So they were very innovative. They developed some interesting tools, like NOACs, for example, but they developed feather wings with wax. Then they flew over the ocean and they realized it's actually working pretty well. Things do what they were projected to do, and they were flying. And then the younger one, Icarus, Bill, they got a little bit over-ambitious because they thought it's a great tool, so let's use it in everybody. And he got fly higher and higher, and you probably know that story. Then the wax started to melt because he was too close to the sun. The father shouted, "Stop doing that, please come down." But Icarus was so imbibed in his glory that he just didn't listen. He flew higher and higher, and so at some point he crashed into the ocean. So just one thing, please, let's prevent Bill from dropping into the ocean. Thank you.
Okay, Bill, how do you answer the Greek mythology?
Yeah, I'm going to revise the pyramid of evidence. You know, you got meta-analysis at the top, RCT, observational research, case reports, expert consensus, new line for the bottom, like well underneath basic science. That's Greek mythology.
Okay, thank you very much. Now let's go to the firing line. And I have two questions that I will pose. I would invite both of you to chime in by hitting your buzzer with your answer. So let's get to the first question, gentlemen. So, exactly what is atrial fibrillation? David.
Okay, so some people say atrial fibrillation is like the gray hair of the head. I actually agree with that. When you look at gray hair, usually you get bald when you get older and older. And if you lose your hair, it's permanent, so they don't come back. So that's atrial fibrillation. It's there and it stays there. And yes, those people need to be anticoagulated because it's bad. But if you hit with a hammer on your body, let's say with chemotherapy, you're also losing your hair, but they'll come back. And that's like perioperative atrial fibrillation. And so that's why you should not treat them the same. Thank you.
Okay, David, I'll give you 1 point for that, even though I am balding and getting gray.
2 points.
Bill.
So, you know, atrial fibrillation, what is it? Depends on who you ask. You know, if you ask the anesthesiologist,
Ask me.
She's going to say, you know, it's really not an intra-op thing. You ask a surgeon, the surgeon's going to say, I asked you first. If you ask the cardiologist, they're going to ask you how long they were monitored for, and the length of the explanation will be directly proportional to the amount of time spent monitoring. If you want to hear about that and more, you can look at David's new book, What is Atrial Fibrillation Anyway? Forward by P.J. Devereaux.
Okay, 2 points, Bill. Okay, next question. In the spirit of perioperative medicine, it's customary to create acronyms to describe disease entities. We've all heard about MINS and BINS. Have you come up with an acronym to describe this new onset perioperative AF? Bill chimes in first.
Oh yeah, funny you should ask of that. AFOTS, atrial fibrillation occurring transiently with stress. No presumption about the pathophysiology, just a recognition that they happen together. AFOTS, coming soon to a clinical trial or registry study near you.
Very good. 2 points for preparation. David.
Bill, I'm not sure, but can I agree with you? I think this acronym is great. You just got the meaning a little bit wrong. I think AFOD stands for all futile and overrated technology stuff. Just look at the patient and then decide. Thank you.
Okay, gentlemen, thank you for your verbal pugilism. It's almost time for our audience to vote. But before we do, let's have one final word from each debater. Bill.
So, you know, in summary, among patients who experience AFOTS, atrial fibrillation occurring transiently with stress, they frequently get AFib again in the future. They have a higher risk of stroke than people that don't, and similar to one that do. And in observational studies, they respond to oral anticoagulation like in the clinical trials. Ladies and gentlemen, if you are an animal, you have fur, your tail wags, and you bark, you are a dog. Ladies, gentlemen, and David, if the rhythm is irregular, does not have P waves, and is picked up on the surface ECG, it is atrial fibrillation, it causes strokes, and it responds to blood thinners.
Ooh, strong words, strong words. Okay, David.
I'm very glad you said that. Look, this is your boss and mentor, Dr. Healy. He's the leader of Artesia. This is a clinical trial looking at subclinical atrial fibrillation, irregular rhythm, no P wave, looking whether anti-coagulation prevents stroke in this population. Do you think he got it wrong?
Well, he's doing a clinical trial, so he must be uncertain.
Okay. So,
Okay.
not all atrial fibrillation is the same. The same is true for perioperative atrial fibrillation. There's no data that these patients benefit and have a safe experience with oral anticoagulation. So let's wait the clinical trials. Thank you.
Okay, gentlemen, the debate is now over. Let's let the audience decide. I do have an audio meter. The decibel response will determine the winner. Actually, it's not an audio meter, it's just my cell phone. So let's have a round of applause then. Who thinks David's potential for multilingual arguing has held the day? David. Okay. Great.
Think about the soft skills.
And who thinks Bill's pro-anticoagulation bluster and muster afforded to the pro argument is worthy of this closeted Winnipeg Jets fan?
Or if you're hungry.
Let's hear it. This is going to be difficult, but the audience has voted, and the winner goes the lanyard spoils. Bill.